Okay. No disclosures. I am also grateful to the organizers of this symposium for inviting me to present this controversial topic. In fact, my initial response to this invitation was the following. But then I looked at our own study we presented at ACC a couple of years ago, and it was one of these administrative databases criticized at this meeting. So out of 90,000 patients with cardiogenic shock due to acute myocardial infarction, 6% were managed with the use of pulmonary artery catheter. So I decided I'll take it on, because it is not people in this room who I need to convince that we need to use pulmonary artery catheter. It is this 94% of community providers who manage cardiogenic shock without pulmonary artery catheter that we need to convince, and this is the task for all of us. So I will start reviewing the evidence available there. And that's how it started. This was the first study that raised the concern about the widespread use of pulmonary artery catheter. It was the prospective cohort study with the propensity-based case-matched analysis of the patients in the ICU. Those who were managed with the use of right heart catheterizations had an increased 30-day mortality after, again, propensity matching to correct for confounding factors. There was an outcry after this study was published. We need a randomized controlled trial. And here it came. So this was a randomized controlled trial about the early use of pulmonary artery catheter in patients with shock and acute respiratory distress syndrome. As you can see, outcomes were miserable. Outcomes were horrible, very high mortality, very poor survival. But PA catheter didn't make an iota difference in these outcomes. And there was another randomized control trial on another large cohort of ICU patients managed with or without PA catheter. And mortality was 68 and 66% respectively. And again, PA catheter didn't make any difference. And of course, there was an escape trial in acute heart failure. And you may say none of these trials were specifically addressing patients in cardiogenic shock on mechanical circulatory support. And you will be correct. But this is the point. We don't have equally quality evidence on use of pulmonary artery catheter in cardiogenic shock on percutaneous MCS. We don't, nothing even close it. And that's why we have to rely somewhat on this randomized control data. Then this came. There was a study, there was actually a paper published in 2013, the author of which proved that the data of PA catheter was inaccurate, number one. Number two, professionals using it had no idea how to interpret it and did it incorrectly. Number three, when they did interpret them, they actually harmed patients because they overreacted to this low cardiac output, low cardiac index, and they were overdosing, not underdosing, inotropes and vasopressors, which is detrimental. So he entitled this paper, Obituary, Pulmonary Artery Catheter, 1970-2013. But then the MCS come on, and it started presenting unique challenges, again prompting us towards the pulmonary artery catheter, because despite of this obituary paper, the use didn't come down, it actually went up. So VA ECMO in cardiogenic shock, we just discussed this. If we don't vent, we are going to end up with this kind of disaster. So should we mandate PA catheter to initiate LV venting on time? But again, there was a paper which was just published presenting this elegant device, which, as you see, goes transeptally, draining blood from the left atrium to the right atrium only if left atrial pressure exceeds right atrial pressure. And they showed that if they use this device prophylactically before any signs of left ventricular distension, 30-day mortality is 5.6%. And if they use it therapeutically, after they prove LV distension, their mortality in the same 30-day interval is actually 34%. So why to monitor the wedge pressure? Why not to just vent everybody? We just goes back to the debate we just had, but they're all interchangeable. They're all connected. And going back to this position statement on cardiogenic shock, which was actually 2017, they do not suggest pulmonary artery catheter as their first line of hemodynamic measurement. Echo, absolutely, because so much parameters can be used from echo. Arterial line, absolutely, for continuous monitoring of invasive blood pressure. Central venous line, absolutely, because this is our mixed venous saturation for calculation of cardiac output and cardiac index. And only if this doesn't help, only if this all is not sufficient, they suggest, and they put it very carefully, the language they use. We suggest the use of PA catheter in case of diagnostic or management uncertainty, or in patients with moderate to severe cardiogenic shock who are unresponsive to initial therapy. Hemodynamic monitoring should complement and not replace other markers of end organ perfusion in cardiogenic shock. And I want to end on this note, that there is no single opinion, even among experts, even among professionals. We all intuitively want to use PA catheter because we want this data. But there is no hard proof. It is more feeling than anything else. And the faster we grow this evidence, the faster we accumulate the facts in support of PA catheter, the sooner we can see that, yes, it is mandated. So far, we don't have enough evidence to state that.
We'll open the discussion. I think there are going to be a lot of questions. Okay, let me start. I think from practical perspective, I think it's nice and dandy and sweet to put those numbers. Practically, how many nurses are allowed to wedge every 4 hours in the CCU, number one? And if you're not able to get the numbers, only plotting one is not going to be enough. So that's an important question to address first. Who's going to be taking charge of serial 4-hour, 6-hour wedge monitoring to see if it's going up or down and what our therapies are doing? Number two, is there standardization? We look at nursing literature for plebostatic access. There is no plebostatic access literature in any medical science in regards to what exactly leveling is and what's the pressures. So if you're going to treat a patient based on the numbers, I think we should really have exact standardization of how to zero and what numbers we're utilizing. I'd like to know the
May I answer your question? I think it's a very good point and valid points. And the answer for that, first of all, if we are not training our nurses, does not mean that's the right thing. We have to train them to do that. In a CT ICU, nurses are doing that. We're training our nurses, we're training our nurse practitioner to do that every certain hours. Number two, what we try to do, get the patient flat. That's what's very important to me, to get the flat numbers and not to have in a semi-setting or 30 or 15. Flat is flat. I'm telling them like Oklahoma flat. You know, Oklahoma is big. Yeah. And to get the patient flat and to get always the number in a flat position to prevent such kind of variation. Otherwise, you're not going to have trends and you will overread and you are not having good quality data to take your decision based on them. That's how we manage that.
It's a joke in our unit. When the surgeons come to round, they keep the transducer high so that we can give volume. If it's a cardiologist, we put the transducer down so that we can give diuretics.
That's why we need a shock team with multidisciplinary rounds.
So I think two great talks. I learned a lot also about the geography of Oklahoma. So, but isn't the real problem that we don't have the, and we spoke about that yesterday, that we don't have the real answers to the values we are getting. I mean, we have a 2.5 day symposium. There is no evidence-based treatment yet. That's full stop, right? There is no evidence-based treatment. It doesn't matter what you measure, you can't answer and help the patient. Therefore, it's so difficult to show that. And from a science perspective, I'm a lot in favoring PACS. But I think there are a lot of non-invasive measurement tools that are coming up in the next couple of years that might that might actually replace the invasive measurements, and that should be very interesting to follow.
PA catheters are absolutely needed. If you have a patient with multiple pressors, you're going to put an A-line. Are you going to use non-invasive monitoring and titrate the blood pressures? You don't. Why are we then arguing then in temporary mechanical circulatory support? It's not the same beast. We're not talking about the sky A, B, and C. We're talking about D and E. So if you're already committing the patient to temporary mechanical support, I think we should get all the numbers. And we already been discussed this morning that if you want to target the sickest and end parameters, I think we've got to collect all the variables, which means invasive hemodynamic monitoring, echo variables have to be there.
Agree?
So I have a question, please. First of all, thank you to the last 4 speakers for the great talks. When we're discussing venting strategies in patients and the use of hemodynamics, I think the hemodynamics or the non-invasive parameters that we use do give us a lot of information on whether the patient needs to be vented. But what they don't tell us is what venting option we should use. So I wanted to ask the panel, if you do see an indication to vent your patient, whether it be the x-rays becoming congested or the hemodynamics are telling you, is there any data that you use to decide what kind of venting strategy you're going to use, whether it's an intra-aortic balloon pump or something else?
If I may start, so we as an institution, Hamburg, vent 100% of all of our patients. That might not be needed, but the big problem is that you do not know how the patient will be in 12 hours. And we have unpublished data that when you start venting when he's already congested, it doesn't help anymore. So that's why we are very, very aggressive about it. We don't know the values, and that's a big problem. We need big studies at these registries showing, and then different timings on when the venting was stopped or initiated to get an idea of it. So we don't, I personally don't know the answer to that question. We vent everyone because we don't want to start LV distension at all.
And sorry, what is your venting strategy?
So we try to, as an institution, we try to get rid of the ECMO as fast as possible. And then we have a venting protocol that we have different hours on different P levels on the impeller if he's not on impeller 5.0 or 5.5.
I can maybe shed a little light on that. So if a patient has chronic a long-standing congestive heart failure in large LV dimensions and has been put on ECMO and is getting a smoky LV and is a good durable VAD candidate, then that's a really good time to call the surgeons and the transplant team in, have them take a look, see what kind of venting strategy they like. In our institution, we have, if we're going to durable VAD, our surgeons like the direct LV puncture VAD, and but I don't think that the Impella and the intra-aortic balloon pump in certain settings is not going to give you enough power to reverse the circumstance.
I just wanted to make 2 statements and address that question as well. So one, I think one of the venting strategies that wasn't discussed at all was actually a Protect Duo to dual drainage, which I think MCW in Milwaukee has presented some good abstracts, and we've done it and successfully done it in a handful of patients. And I think that wasn't discussed in most of the talks. And I think we have a strategy for, we vent with a variety of things. Sometimes we vent, sometimes we don't. When we vent often with an Impella or a Protect Duo to dual drainage. We almost never put in a balloon pump after the fact. I think whoever made the comment that a lot of these balloon pumps are probably in before. But I think this kind of raises the question of one of the reasons to have these shock teams, as Dr. Guglin mentioned, is that you can get multidisciplinary expertise weighing in real time and trying to help manage these patients. Particularly, you have some people like heart failure docs who can't actually do the venting. We can just talk about it. And so you need some talkers, but you also need some doers.
if I could make the comment that so if I could make the comment that I think for venting, it's extremely important. The vents are all much smaller than the ECMO devices. If you're going to put a garden hose in, and then you're going to debate putting an 8 French balloon pump or atrial septostomy, one of these things that seems doesn't make much sense. The vent is the least harmful of all of these. Also, nobody has talked about the 50 cc balloon. Standard balloon, nobody uses 40 cc anymore. If you have the 50 cc on the shelf, works quite well. And in terms of evidence, you just look on an echo. I've seen many times like transthoracic or TE, you could see the aortic valve start to open and you can cause an effect. Turn the balloon pump off, the aortic valve doesn't open. Turn it on, you see it open, see the smoke literally clear. And in terms of the major purpose of the debate about swans, it seems that there's no randomized clinical trial of driving with a muddy windshield with a broken speedometer, but it seems intrinsically obvious that you need to see where you're going. So a swan is really your speedometer, it's your way to see out the window, and there'll never be randomized clinical trials that will please everybody of everything. But of all the things that we do to people in the unit, a swan, assuming you don't drop the lung, is probably the least harmful thing we do, the most potential benefit.
Yeah, so when you talk about venting, hemodynamics, and what to use, I think one of the things that we have to remember is the practicality. I would differentiate shock that's happening in the cath lab, where it makes sense that if you put in an ECMO in the cath lab, you probably can put in an impeller instead of putting a balloon pump, come back if you think you need venting. If you put somebody on an ECMO at bedside at 3 in the morning who's on a bunch of pressors, are you going to move them to the cath lab and then take the risk of movement and put in an impeller, or are you going to put in a balloon pump? So I think the practicality of logistics need us to resegregate shock, not as just STEMI shock, but cath lab shock, OR shock, and ICU shock. So you can really look at these things more practically than, say, put in an impeller, but you can put a bedside impeller at this stage.
And indeed, the major reason of picking up certain device sometimes is who is available to put it in.
I just wanted to make the comment about the non-invasive measures that were brought up by our European colleague. If you're going to have a randomized trial, and that's if. I mentioned earlier, Naveen Kapoor had just come out with, it's in review now, but cardiogenic shock working group. The numbers are pretty staggering. The mortality is cut by half in their hands if you put a PA catheter. And that gets to the question of what was maybe raised by David. It's okay, so that's a working group if you know Naveen, he's a tyrant about hemodynamics. So that is a smooth, well-greased engine. And cut in half the mortality across the sky stages. If you're gonna have a randomized trial, I like the idea of maybe having, instead of having yes versus no, which is what we had with ESCAPE, it's yes, PA catheter versus the non-invasive route, directed protocol with echo, with some evidence-based, and the third one is both, because some of us do both. And we believe in trying to do a pressure volume adjustment at the bedside and say, I don't want to wean this guy because he's done nothing to his LV volumes on his 4th day of ECMO. And the final point I want to make is what Ali said. So what do you want to use a PA catheter for? That's what I have a problem with in all these studies. So what is the end point? If you want to set up a randomized trial, is it at the beginning to define how sick they are? I don't think a lot of us need that. What we do need is, once you put a device in, what the hell is going on? And how accurate is your non-invasive work going to be? So that's where I believe if you want to define escalation, or like Ali said, de-escalation. But then you need, put in a swan, take it out, because I wouldn't leave a swan for 9 days. The average time someone's on ECMO is what, Ali? 6 days? 5 days in the US, 5 or 6? A lot of us just keep the thing in, and I will be the first to admit that there's a lull in day 2 or 3 where you're just waiting for recovery, and we are probably not doing as much with the swan as other people would say.
But the problem is going to be that investigators of such trial are probably sitting in this room or sat in this room last year or so on. And we're all convinced that we need a swan, so nobody will randomize.
See, that is the difference, The difference between religion and science is that we will change science if you show me the data to the contrary, but religion is very different. And here we're almost behaving like this is a religion that we have to put a Swan-Ganz catheter. Then it doesn't matter what I show you, you're not going to take it. The other problem is that when we start quoting that some group cut the mortality in half, I don't know in other hospitals, in my hospital, if the hemoglobin level drops by half, the first thing I do is go and check it again. So it's important that we have reproducible data. Anecdotes will give you hypothesis, will take you in the direction. I think you should not discount it. But at the same time, you cannot hang your hat on it. We need to have randomized data to be strong. I'm sure believers are on both sides, and that's why these debates have gone on. Otherwise, this morning someone said that they have debated the same issues 30 years ago, and we are still sitting and doing the same thing because we don't have the data. If we have to be students of science, we have to pursue data and evidence and then change based on that.
Can the panel or the audience comment on the balloon pump 1-to-1, 1-to-2, 1-to-3 if your primary circulatory is retrograde through the VA ECMO? So this question comes about all the time. So if you're trying to offload the left ventricle, but primarily your perfusion is through the VA ECMO at 4-5 liters, there's going to be a column of blood. You're basically countering the flow of blood from retrograde to the carotid. So is there any idea of 1-to-2, 1-to-3, 1-to-1 offloading as a venting strategy?
Based on your heart rate. If you have a heart rate of 140, I might run it to 1-to-2 because those patients we are going to give complex cases, and your heart rate is not always a normal heart rate in patient. You're requiring ECMO and requiring intra-aortic balloon pump, and I think the heart rate and echo, and I think I agree with David when he's saying you do an echo and you see that when your balloon pump is off, the aortic valve is not opening. The balloon pump is on, the aortic valve is opening. I would, in such kind of case, I would probably run it 1-to-1 because it's unloading more. That means it depends on the case and heart rate. I would decide about that. There's no solutions going to fit all patients. We have multiple varieties of patients, but we have to understand the principle. We have to teach the principle, and then we are going to tailor the therapy for the particular patient. That's complex cases and complex etiology, complex hemodynamics, complex residual function from the heart, complex flow from the ECMO or from impella, and you will not have one solution fits all patients. But the principles are more important to understand the physiology, to understand the circulation, to understand how each pump is working, and then to look to risk benefits from each thing you are doing at the bedside, from everything you are doing, and then you're going to take the right decision for the patient.
I just want to make one comment that the ECMO and unloading, I think when the patients collapse from ECMO, the chronic heart failure patients, as a surgeon, I don't like to take them directly to the permanent VAD. I think it's a good way to do it is the proper way to put a proper device with a full flow and just rehabilitate them, have an idea about the right ventricular function, improve the nutrition, make them walk, and then go for the permanent VAD is a better way.
Yeah, I should have mentioned that our center is a proponent of ECMO to VAD with good results, and that's not a uniform understanding, so you're quite correct.
Just a quick question about LV venting here. Cardiology fellow from Canada. We've talked about venting using different strategies, but one we haven't discussed that I've read about is transaortic catheter venting, 5 to 8 French pigtail, retrograde through the aortic valve attached to the venous limb of ECMO. A couple of Korean and Italian groups have reported interesting outcomes with this technique. It's a lot cheaper than an impella, might work better than a balloon pump. Is there any experience or comments about this strategy?
I can give you my personal experience. We have tried to do initially 5 for the reason for the cost. All 5 times within, I think, 4 hours, they were all clotted.
Also, there's a study in Osayo that the flow through an 8 French pigtail is around about less than 100 mLs per minute. So it really cannot, unload the way that you need, where you need 1 liter, 2 liters of flow. Can I just make one other comment about, we've been, everyone says we need a randomized control trial for this, we need a randomized control trial for that. I think David said it correctly. We're not going to have a randomized control trial for every part of the algorithm. what has to be done is to test an algorithm that has components in it, and that's what's going to happen. And that's kind of one of the nice things about the National Cardiogenic Shock Initiative, if that ever makes it to a randomized trial. You know, there are basic tenets that include, you know, early weaning of inotropes, early use of MCS, and a PAC. So that's 3 pivotal tenets that they're not going to be tested individually. It's got to be tested within the context of an entire treatment algorithm. Because we can't do one clinical trial to answer any question at this point. So we're not going to be able to do multiple trials.
Completely agree, but then we should be able to come up with the algorithm that would work in general, not for one individual group. Because if one group achieves 50% mortality reduction, but is unable to make the recommendation, so this is reproduced in any other group with qualified professionals, this basically doesn't change the field.
If you don't have the data, then you're having expert committees making recommendations, and we all know that camel is a horse designed by a committee.
No, I see. We need a trial, but it will be an algorithm that will be tested, not these individual. I think it will not be the individual components of the trial of the algorithm. It'll be the whole algorithm.
So along those lines, Dan, don't you think that a major tenet is prophylactic unloading versus reactive? And we're sitting here talking about balloon pump, you know, frequency or changing the balloon pump degree of augmentation. That's for weaning in my mind. If you're going to use a balloon in the context of unloading, you use a balloon, you put it 1-to-1, and ideally a bigger balloon than not. So my bias would be to emphasize that algorithm about profile. But what do you think? Or the panel? I mean, is that a major? We keep having these debates about unloading and strategy. Is that the next step?
But every patient is different. Now you put someone on an ECMO, and next thing you know, he's awake and alert, and his extremities are warm and making tons of urine. Would you really need to do anything else? And your outline is showing an arterial pressure, which is nice and pulsatile. Like I heard that we in Germany, I think he said, they're unloading everybody. Would you unload this patient?
Yeah. See, so Bishwajit, I think that's the issue. I think
that's precisely the issue.
Well, let's study that. Let's start with. I think that's a major test.
So that question is answered. Dan's PV loop, he put some slides showing that if the intrinsic LV contractility improves, the PV loop also improves. There's augmented things, so that gives you some guidance. And he himself in his talk said that not everybody needs a PA catheter. So it's still murky, it's going to be very difficult. So you're just getting data. We're not saying that we're going to prophylactically unload everyone, but at least the numbers from the PA catheter, in my mind, is going to help us exactly to see the pattern of what happens with patients who are going on ECMO, and which are the patients who have high wedge, and why do they have high wedge, and so on and so forth.
So Jerry, that was the trial that was conceived by Michael Ibrahim, Christian Bermudez, Michael Acker, and myself. We wrote the reverse trial, which is now in its 2.5 year across 3 centers within Penn Medicine. A combined 250 VA ECMO per year has yielded 19 patients after 2.5 years, trying to look at AMI shock as well as heart failure patients without a very dilated LV, with the primary endpoint at 45 days of being free from MCS, inotropes, or transplant. It's much more of a recovery, but it's exactly what you said. It's upfront, Impella. Like our colleague from Germany said, you could be looking like a rose. And one of the patients was looking exactly like a rose, got the Impella. He did okay. And, but I'm going to tell you, it's tough to enroll. It's tough to enroll in these patients. So the Cardiothoracic Surgery Network is looking to expand it now with the Impella CP. Anyway.
Thank you so much for the speakers. It was a fantastic discussion. Thank you so much.